this is Andrea Kane, and I'm here with you for HSC 114 Medical Terminology, where we're using the Language of Medicine 12th edition by Davie Ellen Chabner. This is now week 13, and we have moved on to chapters 19 and 20, Cancer Medicine, Oncology, and Radiology, as well as Nuclear Medicine. This video is the first of two, and it's on chapter 19, Cancer Medicine. If you are looking at your syllabus, we will be covering unit objectives 9.15.1 through 9.15.8. And if you are looking at your book, these are our chapter goals. We're looking at those medical terms that describe the growth and spread of tumors, looking at terms related to the causes, diagnoses, and treatment of cancer, how tumors are classified and described by pathologists, X-ray studies, lab tests, other procedures that are used for determining the presence and extent of spread, which is known as staging of tumors, and then we'll apply the knowledge to understanding medical terms in their proper contexts. So let's move on. Cancer is characterized by unrestrained and excessive growth of cells. If you want to follow along in your book, you can flip the page and be on 746. Page 746. Anyway, so cancer, this is unrestrained excessive growth of cells. They've just taken off, they've gone rogue, they're doing their own thing, and they are multiplying. And one characteristic of malignant tumors is that they compress, invade, and destroy surrounding tissues. These are aggressive, nasty beasts in the body. Cancer is responsible for 20% of all deaths in the United States. Your book says that's about 550,000 deaths per year. So it's very serious. Now, on the plus side, more than half of people who develop cancer are cured. So even though many people have cancer and they do die from it, more than half who have cancer are cured. And you'll see that as we go through and talk through some of the treatment options available to them. Over the past 10, 15, 20 years, cancer medicine has just expanded, exploded with options that either extend and prolong someone's life that has cancer or definitely put the disease into remission. So quick quiz. If you've read your book already, you probably know the answer to this, but which cancers are the most common causes of death for women? I would suggest you look at the top of page 746 for this information. And the same thing with most common cancer deaths, causes of death for men. I will give you a hint on both of these. Lung is the primary. Lung cancer is the most common cancer death for women as well as for men. And then I'll let you figure out the rest from there. Carcinogenesis. How do cancers begin? What starts them off? What causes them to kick into action? There are environmental agents. Chemicals can cause carcinogenesis. Radiation can. Now, I'm really not happy with how the book put this into your screen for the next one. If you look at your page, which page is it here? 748 into 749. This would be a better way to do it, is to say DNA or RNA changes due to. I wish that's the way that they had labeled this instead of this, because this is very, it's a bit deceiving. If you look at the top of page 749, it talks about how the various kinds of damage to DNA result in malignancy. DNA damage may be caused by toxic chemicals, sunlight, tobacco smoke, and viruses. The specific damage usually involves changes in the cell's DNA codes, creating abnormal genes with changes called mutations. These mutations then interfere with the accurate synthesis of new proteins and can be passed on to new cells during cell division. And that's really the information that you need there. So yes, changes to DNA, RNA, which may be from a virus, which may be from radiation, which may be from other things. Yes, those are all possibilities. And then there's something called oncogenes. And those are also defined here. And I think if you look at top of page 750, you'll see about oncogenes and how those all work together. And then there's also heredity. There are certain types of cancers that can just be caused, that come through, they're inherited. And some Examples of those are on top of page 751 in table 19.2 right here. And so these are genes that are implicated in hereditary cancers. You may have heard of women who choose to get radical mastectomies, even though they don't have cancer, when they find out they have gene BRCA, either 1 or 2. And what they're hoping to do by doing this is by taking away the breast tissue, they're hoping to keep that gene from playing out. Carcinomas are the main type of malignancies that you'll hear about. 90% of all malignancies are carcinomas, which means they come from epithelial tissue. Epithelial tissue. And here's a table, and it's also in your book as well, listing some malignant tumors, all carcinomas of course, and the type of epithelial tissue that they come from. So you can see there's a huge range of where epithelial tissue is found in the body, and these are all types of carcinoma. Sarcomas come from connective tissue. They're about 5% of all malignancies, and sarcomas are very aggressive, typically very aggressive tumors. And here you can see the type of connective tissue. Again, it's everything from bone, muscle, cartilage, fat, blood, nerve tissue, all of that. And these are different types of sarcomas. Then the last 5% fall usually into the category of mixed tissue tumors. These are tumors that can differentiate into both epithelial and connective tissue. So they have mixed two different kinds of tissue. They have the epithelial and the connective that have gone bad. And you'll see these in the kidneys, ovaries, and testes. So, and your book does a really good job of giving you these tables and giving you the details behind those. I'm now on page 754, starting at the bottom of page 754. We're going to talk about gross descriptions versus microscopic descriptions. Gross descriptions mean you see it with your eyes. So if you were a pathologist, and if you're not sure what a pathologist is, please Google pathologist, and it'll give you information about what they are. But the quick answer is those are MDs who choose during residency to specialize in pathology. And that is a position that typically works in the lab, and they are dealing with specimens of all sorts and kinds, looking at them on a cellular microscopic level. But gross is when they first receive, a pathologist first receives the specimen or the biopsy or the tissue or the sample or whatever. The first thing they do is they look at it with their eyes. This is called gross description. They may say it looks cystic or fungigating, inflammatory, medullary, necrotic, polypoid, ulcerating, or verrucous. All of those are defined in your book. So I would suggest you look at that there. Microscopic. This is the second part of what a pathologist does. The first is they look at it with their eyes. They look for they come up with a gross description. Now then they put it under a microscope and they look at it microscopically to look at it more at a detailed cellular level. So terms that you might hear would be alveolar, think lungs, carcinoma in situ, diffuse, dysplastic, epidermoid, follicular, nodular, papillary, pleomorphic, cirrhosis, and undifferentiated. And I want to go back to cirrhosis here for a second. If you think about the liver, we talked about that back in the digestive system chapters 5 and 6, and we talked about cirrhosis. That was without an S. It did not have this S at the beginning. So when we talked about the liver cirrhosis, it started with a C and went all the way through. Now we're talking about the term with an S at the front. And if you look in your book on bottom of page 756, it'll tell you that cirrhosis here is a densely packed tumor. Cirrhosis means hard, so it's a densely packed tumor. It has dense bands of fibrous tissue. All right, grading and staging of tumors. This is really important. If you're around the field of oncology whatsoever, you're definitely going to need to know what grading is versus staging, and that they're both done. Grading is typically done by the pathologist. Staging is typically done by either the surgeon or by the oncologist. Grading is the degree of maturity or differentiation under the microscope of those cells. The better differentiated the cells are, the less aggressive they tend to be. The poorer differentiated that cells are means the more wild, the more aggressive that cancer is going to be. Then you get to stage. Stage is how has it spread in the body. And your book goes over both of these on page 757. Staging, there are three parts to the staging. There's T, N, and M, and you need to know this. T, N, M, tumor, nodes, metastasis. Those three make up the staging. So tumor is just exactly what it sounds like. What is the size and degree of the local extension? Nodes is number of regional lymph nodes that have been invaded by tumor cells, and M is metastasis. How far have the tumor cells spread to distant sites? And those two together are what are used to really come up with a person's prognosis. So, on to cancer treatment, page 758. I again disagree with this slide a little bit. It says here that adjuvant radiation therapy or chemotherapy is after the removal of the primary tumor. That is not true. That is not true. Radiation therapy and chemotherapy are now often used first before a debulking procedure or surgery. Sometimes they can shrink the tumor enough to make the surgery less damaging to the person. So a lot of times you're seeing adjuvant therapy being done before debulking, contrary to what this slide is saying. And that is from real world experience. I have known patients who have had that done for them. I have seen treatment protocols. I have sat in on discussions of cases with pathologists, radiologists, and oncologists, as well as radiation medicine physicians, where they're talking about what they're going to do with patients. So I know this to be true. But anyway, the two things that usually get done are some type of surgery for debulking or removing as much of that primary tissue mass as possible, and radiation therapy and or chemotherapy to try and get rid of cells and shrink the tumors. All right, so what types of surgery might be done? These are terms that you just need to be familiar with: cauterization, core needle biopsy, cryosurgery, en bloc resection, excisional biopsy, exenteration, fine needle aspiration biopsy, fulguration, and incisional biopsy. And these are on page 758, and they're all defined there. You need to know these terms, as you do, as always. And then types of radiation therapy you might hear about. These are terms that you would need to know: brachytherapy, electron beams, external beam radiation or teletherapy, fields, fractionation, gray, linear accelerator, that's the machine used for dispensing the radiation therapy, is the linear accelerator. Photon therapy, proton therapy, radiocurable tumor, radioresistant tumor, radiosensitive tumor, radiosensitizers, and be thinking medications there, simulation, and stereotactic radiosurgery. And these are all listed for you, pages 759 to 760, and you can go through those and read through. The explanations are pretty clear on those, so I'm not going to linger. Whenever radiation therapy is done, whether it is to shrink the tumor before surgery or to kill off any cells that are left over after surgery, there are going to be side effects. Radiation can be a very powerful diagnostic and therapeutic tool. But unfortunately, no matter how careful they are, there will be some side effects, and they're listed here for you. They're also listed in your book at the bottom of page 761. I'm going to give you the example of radiation therapy on a after someone's had their thyroid removed on their throat, on their neck area around where their thyroid was just removed. Even though they create a mask that covers the entire face and head and down to the neck, covers the shoulders, and just has a small opening around the area that is being radiated, there are still these kinds of some of these types of side effects, even though the beam is very, very carefully placed. The amount that's sent in to kill the cells is very carefully calibrated, And and even though they do a lot of protective wear on the patient that's receiving the radiation therapy, these things still do take place. So chemotherapy, that is using some type of agent or biological to attack the cancer cells. And this starts on page 762 and goes into a lot of detail there. So I'm not going to cover a whole lot of that, but really refer you back to pages 762 and 763. Just know that alkylating agents, anti-metabolites, and antimitotics, those three really work to disrupt the replication of the bad cells. They're trying to stop them from replicating. And then this is a table here with some of these chemotherapy agents and the cancers they treat. Gives you an example of each of those. And then this table gives you at the top some regimens, because they found that doing some combinations can be very helpful with certain types of cancer. And then there's immunotherapy. I've talked before about erythropoietin that promotes the growth of red blood cells, and that's something that they may give to help the patient as well. And there's others listed there under immunotherapy agents. And then the last part is the newest anti-cancer drugs and how they act. And that's just there. This is nice information to have, very interesting to look at. It should not be on your quiz. So vocabulary, we have adjuvant chemotherapy, alkylating agents, anaplasia, angiogenesis, antibiotics, antimetabolites, antimitotics, apoptosis. So that's programmed cell death, apoptosis. Benign tumor, biological response modifiers, biological therapy, brachytherapy. Brachytherapy is typically used with prostate cancer, where they put these actual radioisotopes into the tumor itself and they burn themselves out by killing all the cancer cells around where they're placed. It's really kind of cool. It's been around for a long time, but still really neat how it works. Carcinogens, carcinoma, cellular oncogenes, chemotherapy, combination chemotherapy, dedifferentiation, DNA, deoxyribonucleic acid, differentiating agents, differentiation, electron beams, encapsulated external beam irradiation, fields, fractionation, genetic screening, grading tumors. Gray, that is a unit of absorbed radiation, of that absorbed radiation dose. So it's a measurement of how much radiation was absorbed. Gross description of tumors, infiltrative, invasive, irradiation, linear accelerator. If you ever get a chance to go to a new cancer treatment center that's opening, or whether that's a department in a hospital or it's a freestanding facility, and get to walk through before they open it. Of course, I'm talking about the days before COVID. But if you get a chance to do that, it's really super cool to actually see the linear accelerator up close. It's an amazing machine, and what it can do is just phenomenal. So anyway, malignant tumor, mesenchymal, mesenchymal, I'm having a hard time talking today. Metastasis, not metastasis, but metastasis. Microscopic description of tumors, mitosis, mixed tissue tumors. Modality, molecularly targeted therapy, morbidity, mucinous. Mutation, neoplasm, nucleotide, oncogene. Palliative, pedunculated, photon therapy, protocol. Proton therapy, radiation, radiocurable tumor, radioresistant tumor. Radiosensitive tumor, radiosensitizers, that's medication or drugs that increase that sensitivity when you're using radiation. Radiotherapy, relapse, remission. Another spelling error here, watch out for this. This should be a C, ribonucleic acid. So that S at the end needs to be a C. So just make note of that. Sarcoma, serous, sessile. Simulation, solid tumor, staging of tumors, stereotactic radiosurgery. Steroids, surgical procedures to treat cancer, viral oncogenes, virus, and then we're on to the clinical procedures that detect or treat malignancy. And if you are following along in your book, let's see where we are. We are up to page 772, starting at the bottom of page 772. Bone marrow biopsy, bone marrow or stem cell transplant. They use CT. They use they do colonoscopies, which are fiber optic. Exfoliative cytology, where they're rubbing cells off and removing those to be reviewed, assessed, diagnosed. Laparoscopy, mammography, MRI, needle biopsy, radionuclide scans, ultrasound, and x-rays. Now we're on to abbreviations, and there's lots of abbreviations. And they're just here for you. Again, most of these you won't need to know, but it's good for you to at least be familiar with them. METs are a common one. Let's see, PSA, you may hear that. That's a test to look at the level of that antigen in the prostate, which is usually a clue that there's prostate cancer involved. And that is it. I will be back shortly for part 2 for week 13, and hang in there.